Good afternoon, everyone. Thank you for taking time out of your afternoon and joining us for our Go-Live Gotchas webinar. Let's go ahead and get started. I'd like to introduce myself. I'm the Vice President of Sales for the HCI Group and responsible for business development here at HCI. And I'm delighted to be here to introduce our two very distinguished presenters. Dr. Paula is the Chief Medical Informatics Officer and Vice President at Tampa General Hospital. He is responsible for the physician integration and adoption of the $85 million Enterprise EMR project. Tampa General is now electronic in all phases of patient care with over 1,500 physicians actively using their system. Tampa General was just awarded HIMSS Level 6 certification, joining only 5% of the hospitals nationwide in IT infrastructure penetration and usage. I'd like to ask Dr. Paula, would you like to go ahead and say hello?
Hello, Shelby. Thanks for having me.
Great. Thanks for being here. Also joining us is Will Adkins, the Director of Go-Live Services from our HCI team. Will is responsible for leading HCI's Go-Live project team and has provided on-site project leadership for a variety of multi-million-dollar EMR projects. Bringing his many years of project management and training experience on-site to many of the HCI clients throughout the country to lead and coach activation consultants during live activation. He's provided support to dozens of EMR go-lives across the country with various platforms such as Epic, Cerner, McKesson, Allscripts, etc., working with different clients like Lee Memorial, University Medical Center, Texas Tech, Tenet Healthcare, and Santa Clara. Will, please say hello.
Good afternoon, Shelby. Thank you.
Before we get started, I want to share a little bit about HCI. The HCI Group is healthcare information technologies consulting firm based out of Jacksonville, Florida. We have an international presence, including Canada, the UK, and the Middle East. We were recently named as the fastest growing healthcare IT company in the US by the Inc. 500. HCI's focus is supporting clients with EMR implementations and providing support beyond solutions implementations. As I mentioned before, we have extensive experience in the Go-Live area, performing more than 20 EMR Go-Lives. We are software agnostic. We work with Epic, Cerner, McKesson, NextGen, Allscripts, Meditech, and we build our team to match the specific needs of our client based on their technology project. In addition to Go-Live services, we provide technology consulting services on a project or contract engagement to some of the nation's premier health systems such as Johns Hopkins, Mount Sinai Continuum, Cleveland Clinic, HCA, and Community Health Systems. Moving right along, as we're on a tight timeline today, just a bit of housekeeping. All the phones will be on mute with so many attendees out there. The call will be recorded, so please request a copy if you're interested. And questions and comments to follow will happen after the webinar. So if you will submit them to us afterwards, we will make sure to get them answered for you. Today's agenda is going to consist of preparing for your go-live with proper testing, understanding hardware and printer considerations, setting up your command center, engaging the medical staff, establishing and supporting those VIPs, ensuring adequate physician education, and resource planning. And with that, I will turn it over to Will and Dr. Paula to take it away.
Thank you, Shelby. Well, let's go ahead and get started, everyone. Our first gotcha, end-to-end testing. Testing requires a lot of planning and preparation for the timing, sequencing, communication, and training piece. A lot of the successful projects that I've been a part of have had end-to-end testing, and then they've done it again. Thousands of patient scenarios from registration to the discharge process. And in a lot of these different scenarios, one of the things I've seen a few of our clients use is actually have their end users directly involved in the testing process. And this is a great idea. It kind of brings a sense of ownership, and it allows the organization to leverage the resources they already have available. Now Dr. Paula, let me bring you in here to finish up with gotcha number 1 and lead us into gotcha number 2. I've heard you say this to me before. When you think you've done enough testing, do it again, twice. Are there any specific areas like MedRec that you think are important today we should discuss?
Will, on this slide, there's 2 important things I just want to quickly mention. I think the first one has to do with MedRec, and that's the discharge readmit process. A lot of larger hospitals, especially, have freestanding units, either an inpatient rehab facility, a mental health unit, an observation unit, where the patients will actually have to be discharged and readmitted because it's a different CIN. It's actually a different institution as far as CMS is concerned. And it gets very complicated because the patients may have to go back and forth to have surgery, to have different devices implanted, and it gets extremely complicated. So you have to make sure you account for those patient changes in status, observation, inpatient, and then going to a different institution. We ran into some issues when the patient was in the rehab facility and they had to go back to the main hospital to get a CAT scan. It was just a painful process. And I absolutely agree. Getting your end users to get involved, especially your technologists who have to deal with these patients coming in and out of different departments, is extremely important. And then that flows over into med reconciliation. Again, when you're dealing with MedRec, there's so many different disparate systems that are involved. Your application module that has to do with pharmacy, the interaction alerts. So testing deeply with the medications is extremely important. Again, good idea to have your end users involved, your pharmacists, your physicians in this case. So let's go on to the next slide. I think the testing interfaces are another issue that are important, because even if you have an integrated EMR, for example, Tampa General Hospital has an integrated system. We have a pharmacy application inside of our EMR. You still may have outstanding systems that account for medication dispensing or medication safety and cross-referencing. So you have to make sure when you're testing, you account for those interfaces and how they interact with the user and with the EMR. So you have all these different interfaces functioning, so the testing has to take place inside of the main application as well as crossing over. Extremely important. I think that's definitely something that's missed. And as far as the workflows go, you have to make sure that the workflows account for the differences in these systems, because the users, especially the pharmacists, may be working in 2 or 3 different systems simultaneously. Very important, and those workflows have to be defined before you do the testing, because otherwise the testing won't be complete. Okay, next slide.
Absolutely. Let's move on to, you made some great points, Dr. Paula. Let's move on to gotcha number 3, hardware challenges. As their organizational leadership and project and clinical teams move through the process of integrating either to their new EMR system or their very first EMR system, there's going to be a lot of hard questions to ask, and even tougher are the answers to those questions. I wanted to bring up these 6 considerations for you to think about today. Are there enough workstations? What type of workstations do you have now? Pros and cons, mobile versus fixed workstations. Will you have enough room on all of your med rooms? I've seen some pretty small med rooms, and we've had to come up with some pretty creative ideas to put a machine in there so that clinicians could get off the paper MAR and go to the EMR. Do you have a new workflow for isolation patients? I've seen folks use the handheld scanners where they just wipe them down after they leave the room. Or are you guys going to dedicate a CAL for the room or permanent workstations in certain rooms? Switch slides here. And, it's funny, Dr. Paula and I prepared for this presentation. We had so many of the same experiences in so many of the different areas here. And it always seems that there are not enough workstations to go around in the first month post go-live. Clinicians are charting at a very slow rate. Workstations are just being occupied for long period of times as nurses, acuity levels rise and they try to adopt to the system. This is an area you should probably advise your super users and your trainers to be on the lookout for. You want to offer tips for working around other clinicians and being polite when sharing the workstations to keep the frustration levels to a minimum. This is probably going to happen at every single institution. Patient barcode, medication barcode scanners. I was on a project a few months ago, and the barcode scanners were pre-programmed from the vendor. So what they did, they got them in from the vendor. They started taking them out of the box and testing them. And these were all tethered scanners, and they only tested the first batch out of the box. So go-live happens, and then everyone realizes, needless to say, many of the scanners were not programmed properly on the floor. So an entire day was spent removing the faulty scanners from the floor, And then, half the next day was spent trying to get in touch with a vendor to learn how to pre-program those scanners. So a good point here is to test all of your equipment that's coming out, any of your new hardware, and also learn how to reprogram that equipment just in case you need to plan for worst-case scenarios. Printing. Here's another funny story. I was actually on an Epic client in Wyoming, and as I rounded on the 3rd floor to check on my resources, I saw a very upset physician storming past me with a stack of papers in his hands. I go straight to the nursing station, and I asked him, what's going on? Well, the story from the nurses was he had been trying to print his orders from the 2nd floor and had to hit print 30 different times, because the orders didn't come out. And then so the nurses called up to him and said, hey, are you trying to print these? Because they're our printer. So he storms up to the 3rd floor, gets his papers, and storms back down to the 2nd floor. Printer locations and the printer maps are very easily confused and extremely frustrating to end users. A lot of consideration needs to go into that. Now, Dr. Paula, I know you've had your fair share of debates, and what is your take on fixed versus mobile workstations? And also, what other hardware gotchas have you experienced?
Let's talk about the fixed versus mobile first, and I'll move on to some printers and some other issues. I have yet to encounter an organization that overestimated the usage of the mobile workstations. Nearly every institution I've spoken with has underestimated the demand for the mobile workstations and overestimated the demand for the fixed. There's a variety of reasons for this. You can imagine the convenience of having a mobile workstation. It got to the point during our immediate post-go-live period where our nurses were, considering their workstations their own. They were putting flowers on them. They were putting Post-it notes on them with pictures of their family. And we really had to almost have an intervention to make sure that these devices were shared between our nursing staff and our medical staff. So, there's a lot of considerations that go into there. And cost, I know, is a big one, but really look at the usage and invest in your mobile workstations. It will be worthwhile because you will have to stop some altercations if you don't be careful about how many you purchase. And I think that the printer story that Will mentioned was important and appropriate because those are decisions you have to make before go-live. And the classic example is where do prescriptions print? A doctor may be rounding on the 3rd floor and he forgot he had a patient on the 2nd floor, he had to discharge, and he goes to print. Do those prescriptions print at the printer closest to where the user is, or do they print at the nurse's station at the floor where the patient resides? One way or the other, it's the institutional decision, but you have to decide that, and that information has to be disseminated before go-live. Otherwise, those small things will become magnified and just create confusion and really resentment and frustration with the medical staff. So let's go on to the next slide and we'll talk about some more. Yeah, I'll focus on a couple here. Physicians love to bring their own devices. They love iPads. They love Apple products. Unfortunately, most healthcare institutions do not have Apple infrastructure, but doctors love Apple products, so you have to keep that in mind. Make sure that your Citrix accounts for Macintosh products. Make sure that your Wi-Fi accounts for iPads. It's just that's a real gotcha. The overall penetration of Macintosh products in the physician community is much, much higher than in the general public. The other thing is battery life. Battery vendors love to live in fantasy land where every battery gets charged 100% of the time with its full 6 hours of charge. The batteries are placed on the charging stations perfectly with the contact plates being 100% contacted, and the usage is a streamlined level usage, not ups and downs of powering on and off. And anyone who's ever worked in a hospital knows how untrue and how ridiculous that is. So I can tell you, if your vendors are telling you your batteries are going to last 8 hours, expect 4. And account for that when you're purchasing and you're setting aside space for those batteries to be charged. We already talked about the printer issues, and again, the printing problems are magnified because now you have prescription paper, you have dual trays, location issues. Keep that in mind. All right, let's go to the next slide.
Those are some good points, Dr. Paula. We're going to move on to gotcha number 4, our command center methodology. Command center methodology and understanding the difference between the help desk and command center. It's been my experience, and I know that Dr. Paula agrees, your help desk resources are no longer there to fix the username and password issues that they're accustomed to. Help desk resources should attend the same classroom trainings sessions as the end users. Also familiarize themselves with the terminology and the new workflow and policies being implemented. This is very critical that you train your help desk support to learn the new EMR system. As part of HCI's Go-Live methodology, we have a library of best practices, templates to establish a clinical service desk escalation model, communication plan, and shift change methodologies. Don't be afraid to have a dry run, and also I think it pays off to have that 2 or 3 hour orientation with everyone that's going to be involved in your command center. Clearly define your priorities and escalation processes early in the planning stage. Make sure your core measures are being supported properly. You know, all your team members are going to need to be on the same page. Each person on the floor and in the command center should have the same written documentation to explain ticket triage and the priorities each ticket should be. Trust me, I've been on a lot of these go-lives, and every single time a physician has an issue, it is a critical issue, and be prepared. They're going to call you and tell you it is absolutely critical. Dr. Paula, you wouldn't know anything about that, would you?
Well, Will, I'd like to think all of my issues are critical. So I know all my colleagues think their issues are critical. You know, you made a very good point about the help desk. The help desk, the quality of the individual in the help desk really has to be elevated when you're involving EMR support. You need to find individuals that are not just going to be changing passwords, but individuals who have the capacity to understand EMR workflow and how it affects patient care. They need to increase their level of training, need to put them through both physician and nurse training. They're going to be answering questions about both. Some vendors will allow you to send them away to get specialized training at vendor headquarters. I can't emphasize enough on investing in the quality of your help desk, both in the training, the education, and the quality of the personnel. It is absolutely vital. They have to be able to interact professionally with nurses and physicians, and that, you know, and they have to be able to take criticism, let it go over their head, and really interact professionally. I think that was vital to our success. If you go to the next slide, we can talk some more about that. The idea is to have an agreed-upon methodology for your tickets. Like Will just said, I am going to call, and every one of my issues is going to be critical and affect patient care. So we have to agree beforehand, and you need to get your medical staff, medical staff engagement, to agree on what is a critical ticket and what's not. You know, having an antibiotic that you order and another antibiotic is dispensed accidentally, that's a critical issue. That affects patient safety, and that can result in patient harm. Not being able to print out your patient list, yeah, it's annoying and inconvenient, but that is not a patient safety issue. It's still available on the computer. Again, those issues have to be decided beforehand. The decision-making has to be collaborative, and the help desk needs to be able to understand what is a critical issue and what's not, and the methodology of those decisions has to be transparent to everybody. And I think the other item on this slide that's important is the issue tracking. When an issue gets intaked into the help desk, we have to be able to follow it to resolution, and say that this issue was worked on, it was completed, and let's go on to the next one. Very important you have some sort of platform, either software or some methodology for that ticket intake. Very important. All right, next slide. Now, engaging the medical staff. We talked earlier about having the medical staff be involved in collaborative decision-making with things like methodology for tickets, because if you don't do that on the front end, you're going to pay on the back end. And one of the important decisions that I think Tampa General made and a lot of other institutions have made is finding a CMIO. A Chief Medical Informatics Officer is essential to the success of a large-scale EMR project. Now, whether or not that CMIO is going to be full-time or part-time will obviously depend on the size of your institution, but you need to have an engaged, dynamic individual who is going to be out there having cocktails with the medical staff, attending section meetings, shaking hands, you know, putting on the pom-poms, doing whatever is necessary to get the medical staff to be involved in decision-making and to see where the institution is going as a group. Now, one of the things we did right before we went live was have a VIP list. And this list is not just the loudest complainers. It's physicians that do most of the work. You know, if you have 1,000 physicians on staff, you may have 200 that are responsible for 80% of the work. It's the old 80-20 rule. Look at those physicians based on volume, on revenue, on leadership seats at the Med Exec Council, and you have to work diligently to get them on your side. If they aren't, you're liable to suffer a disaster, because all you need is 1 or 2 physicians influential positions to really submarine an entire effort. And once you get those positions involved, get them to help mandate EMR competency. It's absolutely essential that these positions, especially the busy ones, the ones that are responsible for the bulk of that work, that they know how to use the EMR. We would never allow physicians to operate using laparoscopes or the Da Vinci microscope without demonstrating competency. The same principle applies to an EMR, so that training is absolutely mandatory. All right, let's go to the next slide. So the training we just discussed is often underestimated. I know a couple of hospitals that have tried to go entirely with computer-based training, and it did not work out well. Well-designed computer-based training absolutely has a place. The new programs can allow you to go follow workflows, click through. It's a much more interactive experience, but it is absolutely essential, especially in the areas listed there below that have high turnover, the cardiac cath labs, the GE centers, areas that really patients have to get in and out quickly, and when productivity falls, it really causes delays and may cause patient harm. So those physicians really need to be expected to have the 8 to 16 hours of training, and it has to be, some of that has to be at the elbow where the physicians are in the room. And what's a great idea is you get the physicians in the room, and you bring in some of the support staff, maybe the help desk or your support staff, to actually proctor the classes. That works out great. All right, next slide.
All right, well, thank you, Dr. Paula, for that. We're moving on to our gotcha number 7, resource planning and tools. Have you thought about your shift change methodology for your support users? You're going to have all these outside resources coming in. You're going to have your training teams, and everyone else is going to be, it's going to be a chaotic time. So you really need to plan out these methodologies beforehand. We've had a lot of success in the past. Dr. Paula and I were talking about his Go-Live as well, with transition meetings between shifts to go over any of the critical errors, reoccurring errors that happen, training tips, and areas of improvement. It's also a perfect time to make the final adjustments in any of the schedules for your support team. Because as you'll learn as you go live, you'll have some areas that just learn quicker than others, and you're going to need to adjust your support staff to those areas that are having a problem, issues adapting. HCI has also created a lot of templates. Like I said earlier, we have a library of different types of templates, and we have templates for ticketing issues, daily reports for the support resources, nursing managers, command center staff, so that project stakeholders stay well informed and with up-to-date information. That's critical throughout this entire process. Leadership needs to know exactly where the pain points are and which areas are suffering the most. Survival guides that break down everyone's roles, meeting locations and times, important phone numbers, critical escalation processes. All of this needs to be decided well in advance of Go Live, and you really need to focus your attention on being flexible with your resources during Go Live, because you never know where the problem's going to arise. If we take a look at this this slide here, we just have an example of our resource managers and coordinators' daily responsibilities. And this just kind of gives you an idea of how particular you need to be on your Go Live with everybody's roles and responsibilities. Because it's the old adage, well, it's not my job, and it's just going to get, the buck's just going to keep passing down unless you have that accountability. So, Dr. Paula, is there anything that you can add really quickly about your methodology around resource planning and, really engaging the end users during Go Live? And, particular, how did you manage any daily reports on your side during your Go Live?
Thanks, Will. Well, let's talk about the pre, intra, and post Go Live phases quickly. The pre, we talked about one of the important things, and that was identifying your VIP list. So your VIP list, like we described earlier, should include things like volume. Which of your physicians have the highest volume? And that leads into which areas have the highest volume. So if you identify a group of cardiologists who work in the cath lab, and that cath lab sees 50 to 75 patients a day, that is clearly an area that you're going to have to assign specific resources to. And you need to follow that methodology throughout the entire hospital. And some of that's based on patient volume, but you also need to account for physician volume. How do you find out how many physicians are in the area? We had people walking the floors with counters. We used the parking garage logs to see how many physicians were in the hospital at any one time, so we could align our resources with the actual physician count. And then you take that methodology into the intra-go-live period. And as you described, the intra-go-live period is going to be very chaotic, so you need to be very methodical about how you're going to deploy your resources. And what you have to also be is flexible. Your plans pre-go-live may have to absolutely change, and that is where the shift change report comes into play. And we use the SBAR format, the situation, background, assessment, and recommendation. So if we noticed that an area had individuals that were standing around not doing anything, we redeployed them to the areas where they were needed. So if we had, I'll give you an example, we had an excessive amount of support personnel on one of our adult care units, and we redeployed them to the outpatient surgery center, and it was absolutely vital. So you have to be willing to adjust your plans, and that's going to come from your shift assessments when your support personnel come back to the command center. And then post-go-live, you need to do the same thing. How many calls are they getting? How many tickets are going in? And you need to gradually transition from a command center, almost war room mentality, to maybe a live help desk and then a remote help desk. In our case, with a 1,000-bed hospital, that took about 60 days. Smaller hospitals, it may take less, but you need to, just watch your ticket volume and redeploy your resources as necessary. And you absolutely are going to need more resources for the immediate 30 to 60-day period after go-live than you will later on. Go to the next slide.
Excellent points, Dr. Paula. I wish we had more time today. I know you and I could go on for another hour about this. We were talking, preparing for these slides and everything else. I just want to thank you for your time, Dr. Paula. I also want to thank everyone else for their time today. I know we didn't get to everyone's questions, but immediately after this, I'm going to be following up with phone calls and emails this afternoon with some of the questions that we had. Just to kind of give you an idea of what a firm like HCI can do for an organization, during this stressful time. As you prepare for go-live, please feel free to reach out to HCI and allow us to share with you our many lessons learned via our wide network of industry leaders and consultants and SMEs like Dr. Paula and so many more that we have here. Here's a slide with some of what our clients have had to say about us. We welcome you to contact some of our clients, ask them, how we did. Certainly, we would love to talk to you and help you prepare for this stressful time. Again, thank you everybody who attended today. I hope that the presentation provided at least a few unique insights that you can use and take with you and handle the different challenges ahead. So once again, we want to thank you, and we hope everyone has a great afternoon. Thank you very much.